Okay, let's start with Module 1. The first category of breast symptoms is going to be pain and tenderness. So first, let's talk a little bit about the normal breast. We all know that normal breast tissue is lumpy bumpy in a lot of people. So how do we know when a patient has a lump? Today, we're not going to talk a lot about evaluation of lumps. That's in a different lecture. But today, we're going to talk about all the symptoms other than new lumps. Normal breast tissue is also occasionally painful, especially in the premenstrual phase and in the perimenopausal times when there's fluctuation in hormonal levels. So we know that normally patients have lumps and bumps and pain. Also, milky discharge. Breasts are made to make milk, so sometimes they make milk even when there's not a baby around. So a little bit of milky discharge is normal. So here you have 3 symptoms that are normal in a patient: lumps and bumps, pain, and discharge. So how do we determine when a patient actually has symptoms or signs that are concerning? Well, then we ask about changes. Is there something new, a new pain or a new lump or new discharge that's not milky? So in that way, the radiologist becomes the clinical doctor by doing a good history exam and doing a physical examination and then correlating that with imaging findings. Okay, so now we're going to focus on pain for a while. And there are various features of pain that we ask the patient about. We want to know what is the duration, and it makes a difference whether it's an intermittent pain or whether it's a constant pain. Similarly, we can ask about frequency of pain. Is this something which is cyclical and comes every month with menses or not? Lastly, we want to know about the location of the pain. Is the pain diffuse throughout the breast or both breasts, or is it focal? Is the pain just in one area of one breast? And those will make a difference. And we will see that the pain which is constant and focal, those are the pains that are more concerning. Those are the ones that we want to evaluate with imaging. And if a woman is over the age of, say, 30 or 40, depending on your practice, where you work, we will usually start with mammography and spot magnification views if the patient can tolerate it. If the pain is very bad, then we don't do a lot of mammographic images, and we will start with ultrasound. On the other hand, if a woman is under age 30, we will usually start with ultrasound and then only get the mammogram afterwards if we find that it's going to be helpful. Okay, so we're going to talk about different categories of pain. This is the focal pain differential diagnosis with imaging findings. In other words, what are the things that we will see on mammography in a patient who has focal pain? And you will see they're different and they have different treatments. First, abscess. If we're going to diagnose abscess, the key imaging is ultrasound. If we diagnose an abscess with ultrasound, then the patient needs treatment, which might be antibiotics, it might be aspiration, it might be drainage. Secondly, the patient might have trauma, which is causing focal pain. If that's the case, all that is needed is time to heal and follow-up examination, perhaps, to make sure that there isn't an underlying cancer. Third, fibrocystic change can cause focal pain. This is typically a cyst which has become very full of fluid, and it has become tense and tight and full, like a full water balloon, and the patient might need to have aspiration just for relief of pain, but not for diagnostic purposes. Fourth, and very rarely, cancer can cause focal pain. And because occasionally cancer presents with pain, we don't ignore the symptom. We'll do imaging, and if we find findings that look like cancer, then of course the patient will need treatment, which usually involves surgical, excision, radiation therapy perhaps, chemotherapy perhaps. So we always want to keep cancer in the back of our mind, even though it's going to be probably the least likely cause of a focal pain. Another entity we sometimes see is superficial thrombophlebitis or Mondor's disease. And this requires no further treatment other than just supportive care, warm compresses, perhaps some analgesics. So you can see here that making the proper diagnosis of focal pain will lead to the proper management, which is very different for these different conditions. Okay, so we're going to go through these one by one. First, we'll talk about abscess. And remember, the key to this diagnosis is ultrasound. Here's an example of a 27-year-old IV drug abuser who had redness, pain, and swelling in a portion of her breast for about 2 weeks. And on this initial sonographic image, you see there is edema in the breast. We don't really see a focal fluid collection, but we do see that the skin is a little bit thickened. We see a little bit of extracellular fluid here along the planes of the Cooper's ligaments, the fascial planes in the breast. And the tissue generally looks a little bit echogenic. That's going to be the edema. So again, the echogenic fat lobules, the skin thickening, the edema in the tissue planes, and also there's going to be increased vascularity, as we see here on the color flow image. So what this is mastitis, and mastitis usually precedes abscess. First, the patient may have mastitis and then phlegmon and then progress to abscess once the collection becomes more walled off. This is a 14-year-old who presented with the classic symptoms of infection, dolor, calor, and rubor, meaning pain, heat, and redness. And in her, we see a large collection here, which you would call an abscess because it's localized. There's fluid in it, and there's some thicker material, probably some pus and some blood. We see some enhanced through transmission here because of the fluid content. And you can see that it also forms enough of a mass that this would be palpable in addition to painful. So this turned out to be an abscess infected with Klebsiella bacteria, and you can see it's large, it's over 3 centimeters and multiloculated. So this is a complex abscess. So patients that have these complex abscesses often need incision and drainage for treatment. Sometimes a more simpler abscess can be aspirated, but a complex abscess like this usually needs IND. So here she is 3 months later. You can see she has marked improvement. Still a little bit of edema here, a little bit of inflammation probably, but much, much better. So once we diagnose breast abscesses, what is the appropriate treatment? Well, there's really no single right answer. It depends on the findings and on the patient. Always antibiotics are involved. Classically, incision and drainage was the treatment of abscess, but now we're moving away from that a little bit. Sometimes we still use it, but we are trying to do a little bit less aggressive kinds of management now. So unless a patient is in the non-puerperal stage, has a large, complicated, or multiloculated abscess, then we may try to do less. But if it is large, if it's multiseptated, multiloculated, and in a patient who is unlikely to respond well, then they may have to go to IND. What about catheter drainage? In some institutions, catheter drainage is used to treat abscesses. This is variable. It can be very successful, and it is less invasive than surgery. But sometimes it's not ideal because it may leave a tract, for example, in a lactating woman. It might not be the best choice. Also, for some patients, it's difficult to manage a drain. So it's something that can be considered, but all factors have to be taken into account. So I mentioned aspiration. Aspiration is something that we will try, needle aspiration, if the abscess is less than about 3 centimeters in size. Also, if it's not multiloculated. And what we find is that sometimes we need to do serial aspiration. We'll use ultrasound guidance to place the needle in the best part of the abscess. And sometimes it requires several aspirations at roughly weekly intervals, 2, 3, 4, or even 5 aspirations. If it continues to get a little better each time, then we like to continue that process. However, if it's not getting better, then the patient may need a different treatment. So this is an example of an abscess that would be a good candidate for serial aspiration. It's a single cavity, it's well loculated, it's not complex inside in terms of having multiple chambers. So this is one that we would try to treat with serial aspiration. On the other hand, this is probably not a good one for serial aspiration. You can see that it's very big, it's very complex, the material inside looks very thick and heterogeneous, it's multiloculated. This one is probably going to need IND, maybe catheter drainage attempt, but likely IND. So if we do undertake serial aspiration, if there is no improvement after a couple, then those patients may go on to IND. And as I said, some institutions will use catheter drainage, sometimes upfront at the beginning, or sometimes only after aspiration has failed. And as I mentioned earlier, there are some problems with catheters. The lactocutaneous fistulas can be a problem. They can take a long time to heal up. And like I said, it's difficult in nursing patients. Catheters are harder for patients to tolerate because they have to manage the wound and the catheter itself. And in nursing patients, it can be difficult because it's very important for nursing to continue if a patient has an abscess. It's very important to keep the milk moving through because milk that sits in the breast is a wonderful culture medium and the infection can get worse. So we need to make sure that a patient keeps nursing, and if there's a catheter in place, it can interfere with the baby latching on and effective nursing. So sometimes that's not the best solution. Here's an example of a 21-year-old in the non-puerperal phase who had an E. coli abscess. And you can see the infected area here. There's some fluid. It's not completely contained yet, so there's a lot of phlegmon with a developing abscess maybe in the center, but much of the infection is in the surrounding tissue in phlegmon. So she's going to get antibiotics for 10 days, and she got worse. So this is one that went to IR for a catheter, but ultimately needed surgery to have this treated. So what if something that you think is an abscess doesn't resolve? Here's a case of a patient that had a painful area in the right breast. You see the mammogram that shows a lot of benign calcifications bilaterally and this big collection in the right breast. Here we see sonographically, it's very heterogeneous. It's not a nicely contained fluid collection. So you might call this a phlegmon. Turns out this was a diabetic patient, and she had no resolution with the various treatment methods. So we did a core biopsy just to make sure it wasn't cancer. We didn't think it was, but here's the needle going through the area in biopsy, and turned out she did have some E. coli and a lot of fat necrosis, and turns out that she had insulin there because she had been injecting her insulin into her breast because it was a nice, soft, convenient place. So the insulin injections were causing fat necrosis as well as the infection, so not a great idea. So what if focal pain is occurring in a patient over 40? The other ones I showed you were younger. Here we have a 2-view mammogram, and we, like I said, usually do spot magnification views if the patient can tolerate it. And the reason we add the additional views in the older patient is because they have more likelihood of having carcinoma. So we want to give ourselves the best opportunity to make that diagnosis. If they can't tolerate the mammogram, like I said before, then we will go ahead and start with ultrasound. But here's a patient who has a painful area indicated by the triangle on the skin. And you can see there's a little mass deep to it. You also see a biopsy clip. So we wonder, oh, okay, has she had a biopsy? Well, yes, she did. And this is the abscess I showed you a few slides ago, a nice contained abscess suitable for aspiration. And this was a little abscess as a complication of a needle biopsy. So here it is, resolving 2 weeks later. Mammographically, you still see the clip here, and most of the abscess is gone on the mammogram. It's probably a little bit there left, but it's not as easily seen as it is on the mammogram. Here we see this small collection resolving here. Okay, so that was abscess. Our next condition, which causes focal pain, is trauma. If a patient has had trauma and a focal pain, we're going to evaluate it with mammography and ultrasound, especially if the patient is of mammographic age. Here's an example of a patient with trauma. She had a car wreck and had a bad seatbelt injury, which causes a band of density in the breast here. If you didn't know she had trauma, you might think this is cancer, although it has a slightly odd configuration for cancer. But we have the CT here, which was done a few weeks after her trauma because she was still having symptoms in other parts of her trunk as well. But we see very nicely this traumatic injury here to the upper outer part of the breast from the seatbelt of her car. But if the findings aren't clearly due to trauma, then we are forced to give our imaging a BI-RADS4 category, meaning suspicious, and we will recommend biopsy. If, on the other hand, we give the mammographic evaluation a BI-RADS4, suspicious, but we still think it's probably due to trauma, but we're not sure, we can give what's called a discordant recommendation. When we normally give a BI-RADS4 to a mammogram, recommendation is for biopsy. But in this case, we're not quite ready to go to biopsy yet. We want to give the lesion a little bit of time to resolve because we think it is a injury due to trauma. So that would be discordant. So we'll call the mammogram suspicious, BI-RADS category 4, but we will recommend a very short-term follow-up to allow the findings to resolve before intervention. And that might be like a 6 to 8 week follow-up. If the findings don't improve significantly by then we would proceed with biopsy. So here's an example of evolving fat necrosis after a seatbelt injury. In the initial phase, where the patient had pain, we see a heterogeneous collection here. It's not a nice oil cyst or a simple cyst. Could this be an incidental cancer that happens to be right here? Yes, so we give it a little bit of time. Here it is a little bit later. Now you can see it beginning to organize into the different components of fat necrosis, which would be the more serous part and then the more fatty part. And then with time, with further resolution, we have a complete oil cyst with calcifying wall. At this point, it's no problem making the diagnosis. This is clearly benign and fat necrosis. Although you can see in the very early phase, it was more indeterminate and it could have been a cancer, but we give it time to resolve and she could avoid a biopsy. So that's the end of module 1. Thank you very much.